You are listening to Medicine and the Machine with Medscape Editor-in-Chief Eric Topol and Master Storyteller and Clinician Abraham Verghese as they talk with experts around the globe about the hottest topics in healthcare. This podcast is intended for U.S. healthcare professionals only.
Hello, this is Eric Topol, Editor-in-Chief of Medscape, and I'm delighted to have with me Dr. Aaron Neinstein from UCSF in our Medicine and Machine podcast. Welcome, Aaron.
Hi, Eric. It's so great to be here.
Well, I didn't realize all the great work you were doing as Vice President of Digital Health at UCSF, a place I know well from where I did my residency training. But then I read in Nature Medicine in October, our future of AI is better than we think, something like that. And that said, whoa, he gets it. So maybe we can start with that, if it's okay with you. If you could summarize as an endocrinologist, this is, of course, before ChatGPT and the craze that large language models ushered in November and December. What you wrote about in that important Nature Medicine piece?
Yeah, so I will say what I wrote about was my experience as a practicing endocrinologist, and of course spent a lot of my time working in digital health, and realized just how wrong I was about what AI's impacts were going to be on medicine. So, we read all these stories about automation in other industries, and automation replaces people. Farm machinery has replaced farmers, factory automation has replaced factory workers. And as an endocrinologist, I treat a lot of people who have type 1 diabetes. I thought I was going to be next, being replaced in the middle of about 5 years ago. And so, just backing up for 1 second, for people who have type 1 diabetes, their care for many years really involves very close management of using of an insulin pump and continuous glucose monitor. And so the insulin pump is delivering programmed amounts of insulin throughout the day. The continuous glucose monitor is checking their blood sugars throughout the day. And during the beginning part of my career, I would spend visits with patients, and we would download and print out tens of pages of charts and graphs and data, and we'd pore over it trying to look for patterns. And my job was to basically look through these pages and pages of data to try to make recommendations for how they might program their insulin pump differently to improve their glucose management. And that's what it meant to be an endocrinologist, sifting through data, looking for patterns. Well, along comes 2017, and the first automated insulin delivery system came out, and that put an algorithm in the loop. So in between the continuous glucose monitor reading blood sugars and the insulin pump delivering insulin was this algorithm. And so we started, kind of talking in the hallways. Are patients with type 1 diabetes going to need us anymore as endocrinologists? And, I would joke with patients, maybe you don't need me anymore. And I was so wrong. My practice didn't disappear in helping people with type 1 diabetes. It's been transformed for the better. And so what we've realized is that I was a poor substitute for a computer. My patients now are getting better outcomes than they were in the past with this algorithm in the loop. And when people come to see me, rather than us poring over these pages and pages of data, we actually talk and engage with each other. And so I feel like we've been able to develop deeper relationships because I talk to people about what life is like with type 1 diabetes, their challenges, their goals, their needs, their struggles. And I'm no longer trying to be a computer. So I feel like it just opened this world for me to sort of peer into the future and see that AI and machines really should be augmenting the work we do as physicians and returning us from, staring at the computer or trying to be computers back to the bedside and back to spending time with patients. And I mean, you wrote a whole book about this. And so I was really inspired by your book and by my experiences in the clinic to write that piece up in Nature Medicine.
Well, and Aaron, it was really heartwarming I didn't think of endocrinology as the AI, the field, of course, that people jump to right away is radiology or dermatology or even ophthalmology. But, you brought it out, what it can do for managing diabetes. And the quote, it's a one-pager. I recommend everyone to read it who's listening in Nature Medicine. But the last sentence is, what a joy it will be when this becomes a norm and when we can shed the role of being a poor substitute for a machine and reclaim the role of healer. So this is really, I think, the essence of the ideal way we harness digital technology in the future and AI analytics. And the depth that you have in this area is, I think, extraordinary, because it isn't just the use of AI, which we're going to get into with large language models, foundation models, but annotating that, you worked with this organization, Topol, about democratizing. So a lot of people don't realize that when you digitize, you also democratize. So could you tell us that you were a co-founder of Topol, and this is exemplary for how you get people with the condition to be more empowered?
Yeah, thanks, Eric. So one of the challenges we faced for a long time in the diabetes field, people can probably relate to a similar analogy in, many years ago in their own lives, where in the early days of digital cameras, every camera company had its own proprietary file format. You would need a special chip or card from each digital camera. Sony had its own, Canon had its own, Nikon had its own, and the only way to download was using their software. And of course, now everyone uses one piece of software to capture information from every digital camera device. Well, the same thing has been true in the diabetes space. So we have all of these devices, continuous glucose monitors, insulin pumps, glucose meters, and for most of history, the data was kept in, and in many cases still is, kept in proprietary silos. The manufacturer of each device creates the software. They force you to look at the data from the device within that software. And really, I think the key thing that you're touching on, the software they build is built for doctors, not for patients. And so what we tried to do when we established Topol as a nonprofit now a little over 10 years ago, is to create one application where the patient would own their diabetes data. The person with diabetes would own their diabetes data. They could pull it in from any of the devices they were using, and then they are the locus for sharing that information with their medical team. So I think some of the really important concepts that we tried to push forward were the person with the condition being the locus of control of their data, the importance of using device data in care, as opposed to the traditional types of data that we use, in health systems that are in electronic health records. So much of care today really relies on data that lives outside of our electronic health records. So I think that was another really important piece. And then it really helped support telehealth, because even before the pandemic, most of the visits I would do with patients with diabetes would actually be on Zoom and looking at their data on the web in Topol together. So it was a really exciting platform that we put together, built around those concepts.
Yeah, I think it's also noteworthy to say that, we talk a lot about wearable sensors, but it really was the glucose sensors that ushered in the true digital medicine, not, just steps and sleep metrics or heart rate, but, that really was a transformative impact. And being able to have people own their data and have it interoperable between their sensor and their watch or their phone or whatever. I mean, this is really important stuff. Now, you just did what I considered a terrific grand rounds last week, February 9th, UCSF grand rounds with Bob Wachter and your colleagues, Sarah Murray and Atul Butte and Dan Lowenstein, I think. Yeah. So the four of you ganged up and really took on the field of ChatGPT and large language models. So I did want to get into that with you because, in so many ways, your Nature Medicine op-ed was prescient because that was even before these foundation models got the buzz. I wanted to get your views about how this could affect medicine, even more than you've already written. The algorithms, the ability to have virtual scribes, the ability to deal with insurance providers, and all this kind of stuff.
Yeah. So I am very excited about this. I think there are few moments in history where the common person can pick up and see a new technology and realize that the world after may never be the same as the world before. I think the iPhone, many people had a moment like that. Probably the web browser before that was a moment like that. I think we're in another one of those moments. And I think it is equal parts exciting, thrilling, and terrifying to try to think about the consequences and the risks and benefits that are going to come. To your question about how is this going to change practice in medicine, I think, for people who are practicing physicians, we all know, the work we love doing the most is the administrative work, right? It's filling out prior auth forms, filling out school forms, durable medical equipment forms. This is why we went to medical school, right?
Oh, yeah. Oh, sure.
Right. To sit at, late into the night writing notes. So much of medical practice has become consumed by this administrative work and bureaucracy and electronic health records. While they've done so much good, they've become a vessel to kind of put more administrative overhead onto physicians and nurses and other and care providers' plates. And so I think the huge opportunity with AI is to take that work off of our doctors' plates. And so I think my experience in endocrinology is almost hopefully a microcosm for what we'll see, in that we need to return doctors from the computer to the bedside. And we are facing an epidemic right now of burnout in our health systems. As you look across the country over the 3 years of the pandemic, doctors, nurses, frontline care teams, people are burnt out. They are overworked. There have been a lot of articles recently about the moral distress that people feel by working within a system that they don't feel is all of the administrative work is not adding up to better care for our patients. And so I think there are enormous opportunities, and there have been with AI, but I think GPT is now, and large language models are a massive accelerant. As we think about the tasks of, hunting through the electronic health record, this massive amount of data in a chart to find just those few key pieces of data that are important for your decision making, or again, filling out prior authorization or administrative forms, time that we spend up at night documenting to put notes in the electronic health record. And so I see huge opportunity. And where I think the large language models really can accelerate things, I mean, there are many ways they can accelerate things, but traditional AI requires a very precise question being asked of it, requires you to build a workflow or a solution that you put into care delivery, and then you have to train an algorithm to do a specific thing for a specific purpose. This is sort of democratizing AI in a way where the average doctor, of course, we're going to have to work through creating, HIPAA compliant versions that health systems will have, that where medical information is safe to put into these models, and that doesn't exist yet. But the average doctor can sit down and they've got this prompt at their disposal. Microsoft is calling it a co-pilot at their disposal to help them do their work. And so we're already seeing, TikTok videos appear of doctors saying, write the letter for me to United Healthcare. And I have, experimented with this myself, and I have to say, it feels really good as a practicing physician to get that support and that help. And, part of the burnout is that modern medicine, I think, too often ends up pitting the needs of the patient against doctors. So a patient's need becomes more work for the doctor. And I think it's so unfortunate the how this contributes to burnout and even resentment. Patients ask a question of their doctor via email that ends up as a patient portal message, and we hear about how doctors are staying up late at night, foregoing time with their families. They call it pajama time, answering these messages. Well, that's not why we didn't get into medicine, to be upset that our patients are sending us messages and trying to engage. We want more interaction like that. We want patients engaging in their care. And so the problem today is that the technology is not supporting us in providing that level of care that we got into medicine to do. So I just see enormous potential in many of these use cases for large language models to accelerate augmenting what we do as physicians and taking some of this administrative work off of our plates.
No, I couldn't agree with you more, Aaron. And I didn't know about the TikTok about the pre-auth, but I have seen some others that show how well this can be done. And during your grand rounds, your colleague Sarah Murray presented a couple of actual interactions with ChatGPT. I don't know if you want to give us a sense about it. It almost like it exhibited compassion. That is conditioning the written text to be reflective of the style of the physician, of the person. This is something that I think a lot of people, because it's not really understanding language, it's I think what a recent New Yorker article was really excellent about lossless versus lossy compression of language, but it can try to simulate a real doctor's response, and in fact, even the doctor's response. Any comments about that?
I agree. That was a wonderful article on, I think it was called The Blurry Image of Large Language Models or something to that effect. Really a great cautionary story about, not getting over our skis with this new technology as we're, caught up in our excitement. But I agree. I mean, today's GPT is generalized based on the training data it has. We don't yet have versions of this that are trained on our health data, within our HIPAA, protected environments. I imagine a world where I sit down and I've got my own, large language model copilot that is trained on all of my charts from the last 10 years and how I care for people with diabetes, and how I write and how I think. And so when I sit down to, at night, or not night anymore, when I sit down in the afternoon to do my documentation, it's pulling in a version of me, essentially. And could it do that for each practicing physician, trained on the way they practice, their style, as well as, sort of best practices. So I think you can envision these more personalized co-pilots that are augmenting and sort of drafting things for us. And you see a lot of talk on the web and on social media about how there's going to be a premium placed on our ability to prompt these chatbots and AI, and how we write the right questions and write the right prompts to pull information forward. I think it, very analogous to using a calculator, right? A calculator can't do algebra for you. You have to know the concepts. You have to know what to input into the calculator, and you have to know how to place the outputs into context. And I see this in much the same way, in that, as you said, the accuracy may not be perfect with these large language models today, but if, as a trained physician, I'm able to look at the draft and I'm able to edit it, I think that mitigates some of that. And they're not ready to do the work of medicine for us, essentially. I think it's really going to require, today at least, the expert in the middle, but I think enormous promise in drafting language to support our work that is personalized around the way we might practice.
Yeah, I think that it's critical to point out that like as you labeled it appropriately, the iPhone moment kind of thing, where we're just seeing the beginning of large language models. GPT-4 is coming out soon, Sparrow, and all these other new models that go to much higher level of parameters in the trillions. And it's just going to get better. So yes, it's true that we have liabilities here, but we also have tremendous opportunities to harness in the future. Now, one of the things I'm curious as to your thoughts is that, this is kind of prototypic of our medicine and machine story, but medicine isn't really ready for this in this respect that, like, for example, at UCSF, have you put AI in the curriculum at the medical school? Has any medical school done this? Are we going to change the selection criteria for medical students in the future? I mean, there's a lot of things here that are really radical type changes going forward. What are the adjustments in education and training you think that might be well suited?
Well, first I would say, I think as a healthcare system, to get to what you're asking, we need to acknowledge that we need this. We're facing just huge challenges as a healthcare system. Hospitals are overfull. People are having a hard time getting access to care, whether that's primary care is becoming really hard to find. Specialty care is hard to find. I think we need, as a healthcare system, to look in the mirror and acknowledge that we can't just work our way out of this, meaning the one-to-one model of care where asynchronous interaction between a doctor and a patient as the only way that medical care happens is unsustainable. I think acknowledging that is necessary for us to take the next steps forward. And, there was a lot of hope that telehealth would solve this, but realistically, a video visit, yes, it eliminates real estate costs and maybe eliminates geography as a barrier, but at the end of the day, it's still a synchronous interaction. And so it is critical that we look at the amount of care that's needed out there, the problems with disparities, the problems with cost, the problem with access. And we say that we have to have new care models that rely on broader care teams, that rely on technology, that rely on asynchronous engagement, if we're going to deliver the quality and the value of care that's needed in the country. The reason I think we need to acknowledge that first is because there are going to be so many downstream changes required in how we think about medical education, in how we think about training, in how we think about developing systems for care delivery, how we think about what research needs to get done that come downstream of that acknowledgement. So to me, that's the most important first step that we have to take. And the good news is I still teach our first year medical students. I still work. I actually just taught them over the last couple of weeks. I still work with our residents and our fellows, and the next generation is ready for this. In many ways, we need to get out of their way and let them lead on these new use cases, because they're very fluent in what this technology means. They've been raised on these technologies. They understand the implications, and I think they're going to have really phenomenal ideas about what's possible. So I think the more we can, harness the ideas and enthusiasm of the new generation, the more we can include them in developing new systems of care, the better, because they're really an important part of the path forward.
Well, your point about having to embrace this, the step number one, that we really need this is essential, because we haven't yet seen that across the medical community, in particular in reconfiguring education and training. Now, before we wrap up, you're responsible for a lot of digital health at UCSF, which, as I understand it, there's lots of kind of digital groups there that are trying to kind of change the world in many respects, which is great. Are you gearing up for hospital at home? because as we get all these sensors and multimodal AI and large language models that can cross between text and images and speech, we're going to have the power to have people in their home instead of regular hospital rooms at the UCSF Medical Center. Are you gearing up for that?
We are. Like many health systems, we think hospital at home is going to be a very important part of the future. Early data coming out of pilots from other systems around the country have shown benefits with respect to outcomes, cost, patient experience. And so we are also excited about the hospital at home potential. I will say, I think, as you look at the overall care ecosystem, it's really the non-hospital at home, the rest of the care at home that I think is bigger. I mean, chronic illness is a huge burden of disease in this country that unfortunately is only going to get worse as long COVID numbers rise, and we continue to see metabolic disease and obesity on the rise. And so I think hospital at home is a wonderful tool. The number of people it may touch is small. It should have a larger and outsized impact on reducing costs, hopefully, given that hospital costs are such an important driver. But as I think about, the care that touches most people on a day-to-day basis, I think it's really this ability to do more continuous care, like we used Tidepool for many years ago, to interact with people around their chronic condition on a more continuous basis. That's going to have a lot of meaning and impact, moving away from only the synchronous doctor-patient visit as the only way we do care. So I'm really looking forward to transformations in that part of care.
Well, that gets me to the last thing I want to zoom in on, which is empowerment of the patient. I know you've already mentioned that with the work that you did in Tidepool and how it's essential that people have their data and can work with it. But increasingly, we're going to see a lot of diagnoses at least screened for through patient capturing their own data, whether it's heart rhythm, where you already have seen that, urinary tract infections, skin cancers and lesions, ear infections in children, and a long, long list of common conditions that otherwise would require now a doctor clinician diagnosis. And then all these coaching entities, as you know, for diabetes and hypertension and depression and obesity and every chronic condition, using the person's data, and then chatbots with humans in the loop in the backup. So what about this? We tend to only think about on the clinician side. You have had a much broader engagement, knowing how important the patient side of AI, data analytics, data capture. Can you speak to that as to what we should be doing to, not every patient wants to be empowered, wants all their data, obviously, but what should be our best position going forward to help promote that?
Yeah, thank you, Eric. It's a great question. Well, I think several things need to happen, and a lot of them are actually in the policy realm. I think one really important thing that has been made even more important by the unfortunate Supreme Court Dobbs decision are protections around privacy. People are very familiar with HIPAA, and I think there's a false assumption that all health data is protected by HIPAA, and that unfortunately is very untrue. There is a lot of data out there in the consumer world that is not protected by HIPAA. And so I think comprehensive privacy reform is a very important part of this story. And I'm encouraged to see that it tends to be a very bipartisan issue. There are some proposed policies coming through various Congress people. And so I think we will, in the next couple of years, get to privacy reform around consumer data, and that will be very important for health data. I think another very important part of this story is interoperability policy, through Health and Human Services and the Office of the National Coordinator, but really other agencies. we passed the 21st Century Cures Act in 2016, which essentially the core message of 21st Century Cures was that all patients, all people in the United States should be allowed to access their health information without any special effort. And that is making huge differences in people being able to access information from their electronic health record. But as you are implying, what we think of as health data, coming out of the EHR, right? It's the labs you get done from your blood draw. It's the radiology and imaging studies you get done, X-rays and MRIs. But health data is much larger than that. It's the data that's coming from your Apple Watch or your Fitbit. It's the genomics data that you obtain. It's your continuous glucose monitoring data. And those other data sources are growing in size and in importance. And I think just like the privacy policies don't really cover those data, neither do our interoperability policies in a very robust way. And so I think we almost need a more systemic re-envisioning of what the scope of healthcare means, because we need to draw the borders and boundaries much broader around what healthcare is, and that it is occurring in the home and on a continuous basis for people who are using devices, because all of these different policies, technologies that we're building need to apply not just in the hospital setting and not just in the acute care setting, but in the home and outside of our walls setting if we're really going to be successful.
Right. Couldn't agree with you more. Well, just to wrap up, I note that you graduated medical school 28 years after me when you at USC. And so you are a next generation leader of digital health and what will be just called medicine and health, and forget the digital eventually. So we're counting on you, Aaron, to keep up this great work. You're really lighting it up out there, and tremendous regard for you. Getting your thoughts today has been really helpful to provide some anchoring of what are the concerns as well as what is the excitement that we can look forward to. So thanks so much for being with us, and we're going to keep following your work, and let's get on to healing, and let's get away from all this burden of keyboards and papers and authorization and all that hullabaloo. So thanks very much, Aaron.
Thank you, Eric. Great to be with you.